1. Please start, sir. We are live.
Thank you. Dear doctors, a very warm welcome to another episode of Anubhav, an experience sharing by experts, wherein we bring the stalwarts from the field of fertility to discuss difficult to treat cases of infertility. And today's focus is on the couples with cystic fibrosis. But before we move on, let me take you through the brief journey of Justiva Mankind in the Indian pharma industry. Dear friends, with an humble beginning in 1995, Mankind Pharma is today among the top 5 fastest growing pharma companies, with number 1 rank in terms of prescription and 4th in terms of top line revenue. And in 2021, Mankind launched its dedicated gynecological division, Justiva. Justiva is committed towards innovation and developing new therapy areas in field of OBGYN. Over the years, we have well represented ourselves in almost all the major therapeutic segments with leadership position in many. We are among the top 5 in anti-infectives, gynecology, women healthcare, gastroenterology, cardiology, and diabetes, to name a few. We have been also working on innovations in formulation and dosage forms for drug delivery. One of the main factors behind our success for being the fastest growing pharma company is also an operational excellence and strong supply chain, which enables us to reach to the highest coverage of 600,000 pharmacies and 400,000 healthcare providers with largest field force of more than 16,000. In the last couple of years, Mankind has made significant footprint in the field of research and development. Mankind's R&D center is located in Manesar, Delhi NCR. This state-of-art research facility has a dedicated team of over 600 scientists involved in complex and innovative research. Some of our clinical research and biopharmaceutical capabilities include new discovery and research, advanced pharmacokinetic modeling, biostatics, formulation development, and clinical research. Mankind's new drug discovery, research, and pipeline include targets for NASH, arthritis, and diabetes. We are happy to share that recently our novel GPR119 agonist for diabetes mellitus has shown better glycemic control over sitagliptin, and the product is now moved from animal trials to first in human phase 1 trial. Anubhav Case Series is an educational initiative of Drogyna, a brand of dydrogesterone. For recap, let me share the AV of this teaser, which we have shared earlier with you all.
Hello, I'm Dr. Abha Majumdar, Director and Head Center of IVF and Human Reproduction, Department of Obstetrics and Gynecology, Sir Gangaram Hospital, New Delhi. Different facets of infertility with Dr. Abha Majumdar. 2 years ago, we had a patient from the USA, 45 years old, with secondary infertility for the last 6 years, and now she's blessed with a baby boy. Let us take a flashback to the case history. Husband had azoospermia with CABVD, and both partners were diagnosed to have cystic fibrosis. Underwent 4 IVF cycles in USA with husband's sperm with planned PGT-M to rule out cystic fibrosis, but could not reach embryo transfer stage due to poor blastocyst formation. Underwent aid with donor sperm at 36 years age in USA, got pregnant but had IUD at 28 weeks with diagnosis of triploidy. No history of any intervention in the uterine cavity.
Hi Dr. Abha, I am Vineet and this is my wife Pooja. We live in the USA.
We have been married for 20 years and are still not able to start a family. It has been very tough and we have been through a lot. I'm sure it must have been difficult. After trying everything in the USA, we have come to you with a lot of hope. I want you two to be optimistic. We will try our best. IVF ICSI done using donor oocyte and husband's sperm. 2 blastocysts frozen. The couple couldn't travel to India in 2020 for embryo transfer due to COVID restrictions. Pooja and Vineet could finally travel to India. Stay tuned to know their journey of becoming parents.
Now, Lord, we have the honor and privilege to introduce our speaker for this episode of Anubhav, Dr. Abha Majumdar, Director and HOD of IVF and Human Reproduction Department of OBGYN at Sargangaram Hospital, New Delhi. Dr. Abha is holding multiple administrative posts, memberships in various national and international societies like IVF, IFS, FOXY, NARCHI, and ESHRE, to name a few. Dr. Abha has more than 30 chapters of OBGYN books, original articles in index journals. Dr. Abha is a recipient of Dr. B.C. Roy Award in 1999 for outstanding contribution towards medicine and field of specialty, recipient of Abdul Kalam Gold Medal by Global Economic Progress and Research Association in 2015. Before I hand over the session to Dr. Abha, I request all the attendees to kindly post their queries in the chat box and comment section. Now I hand over the session to Dr. Abha for scientific proceedings. Over to you, ma'am.
Thank you, Dr. Shambhu, for having me here on board, and thank you, Mankind Pharma and your gynae division to asking me to share some of my interesting cases. Well, you've already given a small sort of a drama, a play about what really happened. I'll show all of you two cases today. And the first case pertains to what they've already told, but this is not a case of just cystic fibrosis. This is something more that we need to learn. We need to learn from what I saw in my case, and I need all of us to remember that one size does not fit everyone. Case number one is of the girl name changed to Pooja, which is now a 45-year-old lady who lives in US, married for 20 years, who presented with secondary infertility for the last 6 years. Now, when we say secondary infertility, that means...
Ma'am, just requesting you to share the screen, ma'am.
Oh, but I thought it shared. Oh, so sorry. I'll go again. Please wait. Just wait. Okay. Share screen. And is this all right? Okay, can you see me now?
Yes, ma'am, it's visible now, ma'am.
So did you hear me before when I started talking? Could you hear me?
Yes, ma'am, that was audible, ma'am. You can start the case afresh, ma'am.
All right. So the first case is of a lady who is 45-year-old living in USA, married for 20 years. She presented with secondary infertility for the last 6 years. What had happened was that the husband had azoospermia and he had congenital absence of bilateral vas deferens. And then since if the husband has CABVD, we always look for cystic fibrosis in the woman, which they must have done in the US also. And they found both the partners have cystic fibrosis. So they decided that they would do IVF and they would do PGT-M for monogenic disorder, rule out cystic fibrosis in the embryo, and then only go ahead with implantation of the embryo. However, she underwent 4 IVF cycles in the USA with her husband's sperm, but they could not reach embryo transfer stage because there was poor blastocyst formation. And nowadays, all PGTs are done on blastocyst stage of embryo. So eventually they did an artificial insemination with donor sperm when she was 36 years of age in the USA. She did get pregnant, but had intrauterine death of the baby at 28 weeks. And then when the baby was delivered and microarray was done, they found that there was triploidy. That means there was 3 sets of chromosomes for all the chromosomes, the 23 pairs of chromosome. No history of any intervention in the uterine cavity was done. She had a normal delivery. So this was all about her. And then she could never get pregnant, neither with AID or otherwise. So they kept on waiting. And at the age of 43, that was 7 years later, she came to us in early 2020, before the COVID era set in. And we did a IVF ICSI using donor eggs because now it was advanced maternal age and her ovarian reserve had also gone very, very low. And we used husband's sperm. Now, since cystic fibrosis is a autosomal recessive condition, we have to have the same gene from the mother and father. Because we used oocytes from a donor, so we were not bothered about cystic fibrosis, because even if that gene went from the father's sperm, it was a recessive condition and would not have caused any disease to the baby. So we used donor oocytes, used husband sperms, and we had 2 blastocysts which formed, which we froze. She could not come back to India for embryo transfer during the first wave of COVID-19. And hence she reached India in 2021 April for embryo transfer for 3 months. So she had her IVF in early 2020, had to, very fortunately, was back to US, but then she could not travel back because there was total lockdown, and hence she came to us in April 2021. Now, before she came to me, she was on Zoom teleconsultation. So I started her on oral contraceptive pills 2 cycles before she traveled back to India, and she reached India in April with her last menstrual period being on 7th of April. Now I'm bringing you absolute facts over here. She had come only for 3 months. I started her immediately on oral estradiol valerate 2 milligram TDS. She did say that she did have regular menstruation, but they were becoming very scanty, but her ovarian reserve was very, very low. Endometrial thickness was only 4.2 millimeter on the 21st of April, which was like a shock to me, which was after 14 days of estradiol valerate replacement. So I added another route of estrogen by giving her estradiol gel, which gives 1.25 milligram of estradiol on a single dose. So 3 times a day that was added, along with the oral estradiol valerate, which was 2 milligrams every dose. But then after 7 days, the endometrial thickness just did not move. And she was a Chandigarh-based patient. She was having her ultrasound in Milan, Chandigarh. And I've also enclosed a report of the ultrasound over there, where you can see that this endometrium from their ultrasonologist was reported to be in between 3.8 to 4.8 maximum at different places. I didn't have any option. I gave her medroxyprogesterone acetate 10 milligrams twice a day for 5 days and induced a withdrawal bleeding on the 10th of May. And I started her again, starting with oral plus the gel for 15 days. Endometrium remained the same. It was 4.4 millimeter. 3D ultrasound was normal, did not show any synechia, anything. However, I was tied up with time. I had to do something because she was destined to go back in early July. And I had just June with me. So I said, I have to put in a scope, even though the ultrasound is normal, 3D doesn't show a synechia or any problem, but this endometrium is just not responding. So I did a hysteroscopy, and this was the picture when I entered her uterine cavity. Now you can see a small sort of ostia over here. Was this the ostia or it was something else? I had to dare and go into it and see. I just tried to snip off a little bit, and I immediately withdrew my scissor because I thought this was a perforation of the uterus. But you can see a small ostia inside this area. And that is where I got a little courage, and I started excising the whole wall, and there was a synechia all across the fundus till the other ostia, which you will see over here. So this was so important that the 3D did not reveal anything, and I had to do a hysteroscopy because the endometrium would not buzz more than 4 point something. And you can see that there was such a decided dip, and look at the other side also. So this was a complete endometrial synechia across the fundus. So what I did was, I had already given 14 days of oral estradiol valerate and gel of estradiol, which I continued after hysteroscopy from 24th May onwards. On 18th June, I did another ultrasound. It was again done at the Milan Center in Chandigarh only, and the endometrial thickness was 4.5. I did not know what to do. This patient had to go back. I have never instilled PRP, that is plasma, platelet-rich plasma, ever in my life to any patient. I was desperate. So I instilled two platelet-rich plasma, once on 21st and the other on the 23rd of June. I called her to Delhi. I said, no more Chandigarh, now you come over here. And as you see, the last was ET 4.5. 18/6 was the date. So I called her here, and the PRP installation had 7.1 lakh platelet in one and 6.9 lakh platelet concentration in the second one. After the first administration, my endometrium grew a little bit. It came up to, with difficulty, 5.3. It was ideally 5.1 only. I did not wait anymore because I had seen her endometrial cavity. I had resected her synechia. The endometrium grew till almost 5.1 to 5.3. I started progesterone on the 27th of June, and I did an embryo transfer on 22nd of July, that is 5 days after administration of progesterone, with an endometrial thickness at the most was 5.3. And this is how, these are the prescriptions for PRP installation, where I instilled about 1 ml, even less than that, with a concentrate which is written over here, and the endometrial thickness was 5.3, did not increase after the second installation. So it was very, very wasteful. However, I could not wait anymore. So 1 day later, on 25th, I started her with Crinon gel twice a day, 90 milligram, 8%, and a folic acid tablet. And I did an embryo transfer on the 2nd of July. You see in the prescription, everything, her prescriptions are original prescriptions. And beta HCG on the 13th of July was 400 MIU. Cardiac activity was seen on the 3rd of August 2021. And then eventually she had a cesarean in the US because she went back in August. She could not stay here anymore because she was not allowed. She just had her period for extended till August. And LSCS was done and a live male child was delivered. So all I want to tell you is what lessons I learned was, don't chase the endometrium if you are confident about the cavity and have also done a hysteroscopy. Embryo transfer of a good embryo on a suboptimal looking endometrium quite often results in a pregnancy. And this is not once. Every time this belief becomes stronger and stronger in my heart, that we uselessly chase very nice thin endometriums, which are triple line in characteristic, which are 5 millimeter, and we want them to grow more. And hence we refrain from embryo transfer. If I would have refrained from embryo transfer and called her again from the US and then done a transfer, maybe it would have worked, but she would have lost very important time in her life. I bring to you another case also over here, which is quite similar, yet teaches us much more than what the first case taught. Now, this girl is a 35-year-old lady, married for 5 years. She presented with primary infertility since marriage. She is a known case of congenital hypogonadotropic hypogonadism. And if you all know what happens in congenital hypogonadotropic hypogonadism is that the patient or the woman does not start menstruation herself. And because there is a deficiency of hormones coming from the hypothalamus pituitary to the ovary, and hence she does not ovulate. She does not ovulate, so she does not get her menstruation. So what is important is that when girls come to us at 16, 17 years of age and we find this diagnosis, at that time we give them hormone replacement therapy so that she has her normal sexual characteristic development. She starts having menstruation, and there is a lot of psychological improvement if the girl feels that she is menstruating. But then when she wants a child, these women need to start ovulating, for which only gonadotropin works. However, she used to get a withdrawal bleeding on HRT where she was always primed with estradiol valerate, and then the withdrawal was induced by medroxyprogesterone acetate. She went to another IVF center in Delhi, and incidentally, a complete uterine septum was seen. And as we all, I follow a dictum which is known as masterly inactivity and timely intervention. But this masterly inactivity is very difficult to achieve. You see a complete uterine septum and you run to resect it. This is what we do in haste. If we leave the septum also, nothing wrong is going to happen. Yes, the chances of miscarriage is there, but there is a chance also that she could conceive naturally and go up to term. I've just done a cesarean 3 days ago of a woman where I did not touch her uterine septum. She was pregnant for the first time with IVF, and she delivered a baby by cesarean 3 days ago. However, this was resected. And on the other hand, what did they do was donor oocyte IVF was done at the same center, and 4 blastocysts were frozen. But then they could never do embryo transfer because the endometrium always remained thin for her. They went on chasing it. So we went to another private IVF center in August 21, where she was started on anti-tuberculous treatment in view of a thin endometrium because her quantiferon TB gold test was positive. If we look at our population, then Montux and TB gold test positive is there in 40% of us, which are screening tests for tuberculosis, never prove that you have genital tuberculosis. However, she was in hands of our clinicians who thought that every thin endometrium is maybe tuberculosis. Then she came to us in October 2021. I did a 3D ultrasound of the pelvis, which showed a normal uterine cavity. We stopped her ATT. I did 1 cycle of gonadotropin stimulated IUI, and the gonadotropin is always a combination of FSH and LH. So HMG is a good option for this, which failed, and her endometrium was only 5.2 millimeter at the end of it. In the second stimulated cycle, the semen sample was not adequate, and therefore IUI had to be cancelled. I counseled her for IVF. But before that, when I thought that this endometrium was too little in IUI gonadotropin stimulated cycle, I convinced her that I have to go in with a hysteroscope inside to see after septal resection, are there any synechia in the uterine cavity? I did a synecholysis, and we proceeded with IVF with her self oocytes in a hypo, and we retrieved 7 oocytes. We did a day 3 to embryo fresh transfer at an endometrial thickness which was still 6.3, and we froze 1 day 6 5 BB blastocyst. She did not get pregnant. The fresh transfer failed. Endometrial preparation for frozen embryo transfer was done using HRT, that is tablet estradiol valerate and estradiol gel, in May 2022, which is just about 4 months ago. Endometrial thickness after 22 days of endometrial preparation was 5.3 millimeter with a pocket of fluid in cavity. Now I'll just go back. I did not do a hysteroscopy after her. Just let me go back to the last slide. Okay, IUI was cancelled. We counseled her for IVF and went ahead with IVF, did a fresh embryo transfer. It did not work. While we were preparing her on a HRT, we found a fluid pocket in the cavity. It rose a question in my mind that is there a synechia which is formed? And that is when I put in a hysteroscope on the 3rd of June and revealed a thick fundal synechia, which I just snipped off. There was nothing else over there. Again, I did her endometrial preparation from day post synecholysis using HRT with estradiol valerate and gel both. And after that, gave her vaginal micronized progesterone. Endometrial thickness on day when I started progesterone was 6.7 mm, triple line. Did a frozen embryo transfer. Beta HCG on the 2nd of July was 382. And currently she's 18 weeks pregnant. You can see the dates of her pregnancy, which are here. I don't know if you can see the date, but yes, 26/9/22. This is the girl who is now pregnant. So all I want to tell you is what lessons we learned from this case is hypogonadotropic hypogonadism patients do not require donor oocytes, as they make their own oocytes with gonadotropin very comfortably. Decision regarding septal resection should be made wisely, as it can sometimes do more harm than good if not done aptly. ATT is not the treatment for all thin endometrium. And last of all, thin endometrium, especially if there is history of intervention in the uterine cavity. So because she had a septal resection, and then I saw some fluid in the cavity when I was preparing her with HRT, I think hysteroscopy was very important. And when I found that fundal synechia, I just snipped it off. The endometrium did not grow very much. It was 6.3. But according to me, because I'm sure of what hysteroscopies I do, I was sure that there's nothing else inside and this endometrium will not grow anymore. We did an embryo transfer and we succeeded. This is all I wanted you all to say, that thin endometrium does not stop us from doing embryo transfer. Please do not stop. PRP is not the answer. Yes, when we are desperate, we try to use all methodologies, which was used in the first case, but I do not recommend the routine use of PRP in such patients. Only because the endometrium was 4.8 and I did not even reach 5 millimeter. Therefore, in desperation, I used it, but then also it was like 5.1 to 5.3. So any endometrium will implant if the cavity is regular, the endometrium characteristic is good, and your embryos are good. Thank you very much for hearing me out. But then now I'm open to questions, and I would be happy to answer any questions which you want me to.
Thank you, ma'am. Now we have received few questions. The first question is related to first case which you have presented. I think the subfertility rate in cystic fibrosis is very huge. It is 35%. So congratulations for this particular success. Now, doctors have asked what is the ovulation induction protocol was used in the cystic fibrosis patient, the first case. What protocol
First
did you
case
use?
was donor eggs. So why will I use a different protocol? It was, the lady was 45 years when she came to me. So I could not have thought that I'm going to retrieve with an AMH of less than 0.1 nanograms. So I did not use her eggs because 45 is a high age and I need a lot of embryos to be able to do a PGTM. So the best was use the husband's sperms because it is an autosomal recessive disorder, and use donor oocytes. So donor oocyte is stimulated with absolutely normally 150 to 200 units of any recombinant gonadotropin in my unit.
Fine, ma'am. Now, what prompted you to go for hysteroscopy in this patient? What was the red flags which you
She did
seen?
have a delivery, and that was intrauterine death about 7 years ago in the US, where I took a very deep history that did they do a manual removal of placenta? Did they do a suction? Did they do a DNC, which she did not give to me. But her endometrium just would not buzz from 4.5 millimeter ahead. So I had to think that, there is something to her, that she did conceive earlier, she delivered, no intervention was done, but a pregnancy delivery maybe was enough intervention. And sometimes, a manual removal of placenta or maybe even more smaller procedure is not recorded or not told to the patient. So I thought I need to put in a hysteroscope. I would not give up on a 4.5 millimeter endometrium saying a 3D ultrasound is the answer for it only. I will do a 3D, but if the endometrium just doesn't grow, I will 100% put in a hysteroscope to see why her endometrium is not growing. And if I would have found nothing, I would have been happy at that. And I would have done a transfer at whatever endometrium I had.
Fine, ma'am. I think there are a few questions related to hysteroscopy only. So what is the best time for hysteroscopy if done for fluid in cavity or thin endometrium?
I think it is best when we are on a estrogenic phase where we can continue the estrogen, because estrogen is the building stone for the endometrium. Progesterone causes coiling of the endometrium and secretory changes. So she should never be post-ovulatory. It is always good that she's pre-ovulatory, and we can continue to give her estrogen after the hysteroscopic synecholysis so that her serum levels of estrogen go on rising and we can have the building molecule for her endometrium provided in her blood.
And there's a follow-up question. Suppose we see fluid in the cavity while patient is on HRT. Do you plan hysteroscopy for the same immediately while on HRT, or wait for menses and then plan immediately after?
Yeah, if I see fluid in the cavity and it is a absolutely normal triple line endometrium, 7 or 8 millimeter, I would not even think of doing a hysteroscopy, especially if there was no intervention of delivery or abortion for her. A little bit of fluid in the cavity is quite commonly seen. When the endometrium grows very well, a little fluid could be secreted. Maybe what I do in such cases is put them on a course of doxycycline and a probiotic like Ecoflora or Ovitas BV, and it helps. Sometimes the fluid disappears, sometimes it doesn't. But I would only do a hysteroscopy if she had a delivery before, or she had any type of intervention in the form of miscarriage with or without DNC, or a hysteroscopic procedure. I will not do it the same day at all. If I have to do it, I will do it after her menses maybe.
I think there are a lot of questions related to hysteroscopy only. So T-shaped cavity requires lateral metroplasty, ma'am, because volume of cavity is very less. So your take on that?
Upma, this is a very controversial subject. It is a very controversial point. Sometimes the lateral metroplasty leads to no benefit. In fact, it leads to more secondary fibrosis. So I feel if the endometrium is growing fine, even if the cavity is looking shrunken and T-shaped, it is best to refrain from metroplasty. Just putting in a hysteroscope and doing something is not necessary. We can just put in a hysteroscope, and if we see there's no synechia, absolutely, we can leave it. But still, some people feel very strongly about doing a lateral metroplasty. However, I would want to just add one thing. It is better not to use a current for this. It is best to use a scissor, because secondary fibrosis is less if we cut, but it is more if we use current.
I think, ma'am, you need to allay some of confusions related to thin endometrium. So what exactly we look into endometrium when we decide to have an embryo transfer? What's your viewpoint? Because a lot of confusion regarding the thickness.
That is why I brought these cases up here. Like Surekha said, why did you not use sildenafil? Who says sildenafil will increase the endometrium? If it was, the whole world would be using it. There are few studies here and there with very, very weak studies where there's no control group. These are not prospective randomized controlled trials. Why will I use sildenafil? Have you used it, Surekha? Look at the side effects. Do you know how severe headache these girls get? Maybe 20 years ago, I had once tried to use in maybe 10 patients. We did not get any success. Instead, some patients had such severe headaches because of increased their incidence of vascular headaches also increased. So these are not proven treatment. Even PRP, I don't recommend. I would not have written PRP, but I wanted to be honest about what I did in that case. I would not say that PRP helped at all. But yes, in literature, there have been studies which are not, again, randomized controlled trials. They are cohort studies which have shown some improvement on PRP. And because this lady had to go back in July, I had no option that I could do another cycle and wait and see if my endometrium could grow. So even after 25 days, I just put in some PRP. And when I put it second time and there was no increase, I did her embryo transfer at 5.1 endometrium only.
Fine, ma'am. So again, can we continue estrogen along with hysteroscopy?
Yes, I did this in the first case. You've seen it. But you know, your hysteroscopy has to be very, very beautifully done. It has to be atraumatic. You have to go in bloodlessly. Then only you can see the synechia of the magnitude which I showed in my case. Otherwise, people generally feel that that is the ostia and they think, oh, everything looks normal. One drop of blood in the cavity and the whole vision is gone. So if you can do such a nice hysteroscopy and you can cut across the cavity with the synechia, I'm sure you can continue with estrogen as I did, and then went ahead to do a transfer in the same cycle. But otherwise, you will have to give her estrogen, whether you give it in the same cycle or you give it in the next cycle. If you stop, give her meprate, induce a withdrawal bleed, and then do a hysteroscopy, then also you will give her estrogen. Why not give it now only?
Fine, ma'am. So any role of GCF?
See, all these drugs, PRP, GCSF, sildenafil, vitamin E high doses, aspirin, pentoxifylline has been explored in thin endometrium, and nothing has come on the tabletop as recommended treatment. Nobody says that any of this is a proven treatment. So it's no, why I used PRP is only probably in desperation. I still do not recommend that we would use, and I do not use it for my patients. This is the first time in my career of 35 years that I used PRP in a patient. So it was quite desperate that I could not understand why this girl is not growing, and she did get pregnant 7 years ago, but she got pregnant on 5.3. So where is your problem? I mean, I am doing embryo transfers below 6 in a lot of patients where I'm sure that this is good characteristic endometrium. It is, there is no synechia inside. I have done a hysteroscopy myself, and we go ahead. I feel more is to learn from this, that see, on a 5.3 millimeter, a live birth happened in a 45, 46-year-old woman. Why will it not happen in younger women? So that is more important for us to, and increasing the dose from 8 to 10, I did increase once upon a time. But now I find that 6 milligram, nothing happens if you go on increasing the dose. You give 2 tablets TDS, you are just increasing one route. I feel that giving it from 2 routes is better, because liver metabolism is still going to be the same. Whatever is reaching the uterus is still going to be the same. In a injectable cycle where we do for normal patients, IVF, controlled ovarian stimulation, where the estrogen levels go up to 1,000, also the serum levels, endometrium doesn't grow, then increasing the dose will not grow it. Correcting the disorder will let it grow, or maybe we can add estrogen from a different route. Why HRT does not work in all patients is because, however similar to the natural molecule which we make in our body, it may be, but the receptors may have decreased receptivity to the external exogenous estrogen which we are giving. And hence, a lot of times, natural cycle endometrium grows better. In gonadotropin-induced ovulation cycles, endometrium grows better. But in HRT cycle, it grows, for some patients, less than what it grows in a natural cycle. So if it doesn't grow on a HRT cycle and on the day of egg pickup, the endometrium was good, I would say don't give her HRT. In the next cycle, go for a natural cycle. And if she's not ovulating regularly, you can give her a small dose of gonadotropin to make her ovulate and let the endometrium grow.
I think, ma'am, there is another question related to estrogen only. So any difference between micronized estrogen and estradiol
Estradiol
valerate?
valerate is considered micronized only, Charu. So I don't think there is any difference. I don't know if any estrogen is available by the name of micronized estrogen, because estradiol valerate is supposed to be closest to the estradiol which our ovary makes for our own body.
Thank you, ma'am. I think there's one more question, which is progesterone given by gel enough, or should we give third day IM progesterone or vaginal progesterone 400 BD?
We have done a lot of research on this, and we are still doing more research because papers go on coming that IM progesterone is good. But if you know the pharmacodynamics, then vaginal progesterone has a first pass effect on the uterine endometrium, and therefore the concentration is highest in the uterine endometrium, but the serum has a lower concentration. The moment we add injectable, we get a very good feeling because the serum progesterone goes up. How much goes to the endometrium, I don't know. However, I'm practicing IVF for so many years now. And I think over the last, what is it now, 2022, since 2012 or 13, or maybe 14, I stopped using injectable totally for my patients. So my plus point, which I tell them, is that luteal phase support will only be by 1 vaginal progesterone. And if it is a HRT cycle, by maybe 1 or 2 estrogens and a folic acid tablet. We will not use any injectable for you. However, there are studies which say that if serum progesterone is low in a HRT cycle 1 day before adding progesterone, before doing the embryo transfer, then maybe injectable progesterone can be added as rescue progesterone for the patient. But we need randomized controlled trials to say that yes, injectable really helps. We understand that when the progesterone levels are low on the day of embryo transfer, the pregnancy rates are slightly lower, the miscarriage rate is higher, and our own study says that. But that does not make us add injectables for the other 75% where the progesterone levels are good. So I feel at the moment, at least, I'm not in a position to say that added progesterone is required. I still continue to do it only on one vaginal source of progesterone. Do not use an oral or injectable progesterone in my patients.
Fine, ma'am. So thank you very much for such an elaborative explanations for all the questions which are being raised on this forum. Once again, you have, I think, a lot of fears and misconceptions have been allayed regarding cystic fibrosis infertility management. And thanks for your experience on controversial things. You have allayed many difficult situations. With this, we conclude the session over here. Before concluding, if you wish to add something to it, most welcome, ma'am. Otherwise, we conclude the session over here.
Today, the most controversial topic is only two in patients undergoing IVF. One is a poor responder, and we don't know the best regime for them. And number two is the thin endometrium, where we don't know the final answer for them. But at least we need to rule out a diseased endometrium. Endometrium which has synechia. If we can rule that out, then whatever endometrium you are making on estrogen, the highest, longest duration could be anything. It could be 30 days also. It could be less than that also. There is no need to refrain from embryo transfer, because endometrium less than 6 also leads to pregnancy if you have good embryos. So if you have 2, 3, 4 good embryos, in our center, we do elective single embryo transfer only. So I would say I would definitely put in one embryo at whatever endometrium we have. If I've done a hysteroscopy, I'm sure of the endometrial cavity, and whatever maximum I've got with either a natural cycle, natural ovulatory cycle endometrium, or HRT by 2 sources of estrogen, which is dermal as well as oral. If I get an endometrium of 5.5 or 6, I will definitely go ahead with the embryo transfer. And this is the message I want to give all of you, that please do not stop embryo transfers for these girls if you are sure that the endometrium is normal. But do not forget to put in a hysteroscope and ask the best persons to do a hysteroscopy for that person. Do not mix up that, if you are good in IVF, maybe you may be good in hysteroscopy, you may not be. So ask someone whom you trust best for a hysteroscopy to go in with a hysteroscope bloodlessly, and you will be able to detect a synechia as small as was in the first patient.
Thank you, ma'am. I also like to thank all the attendees for their active participation, for their thought-provoking questions. With this, we end the session of this Anubhav case series. Thank you very much. Have a safe good night. Thank you very much, sir.